ladies and gentlemen, welcome to this edition of the Cameroon Town Hall for Healthcare Professionals. This is the 51st edition since we started this platform. Cameroon Town Hall for Healthcare Professionals is a platform that brings together healthcare professionals from Cameroon origin who are spread across the globe. We have now more than 1,245 members registered on our database, and we are in more than 34 countries now. This is an initiative that has been on for almost 2 years today, and Christelle was just saying very soon we shall be 3 years old. What an amazing journey. Today we shall be discussing a very important healthcare topic, which has to do with cholera. Cholera, as some people say, is a disease of the poor, disease of hygiene and sanitation. We shall find out why our country is having this situation right now. Of course, today with me, we shall be having Dr. Christelle, who is going to co-moderate with me. Christelle, hello, bonjour.
Bonjour, bonsoir Elvis, bonsoir à chacun et à chacune. Bienvenue à cette 51e édition de Cameroon Town Hall. Aujourd'hui, nous avons l'honneur d'accueillir Dr. Fouda qui nous parlera de la situation avec le choléra dans notre pays. Merci.
Merci beaucoup, Christelle, and it's going to be an interesting presentation. We've always had very interesting presenters, people who take time to do their research, to do their work, and people who we consider as trusted authority in every topic that we do bring here at the Cameroon Town Hall for Healthcare Professionals. And of course, we are always having a pleasure of being here with our chair, Dr. Muno Ken. Hi, Doctor.
Hello, Elvis, and I just want to thank all the moderators and everyone who is here. It's always a pleasure joining you. And today is really one of those topics which goes down to the core of healthcare. And I think we have a trusted authority in this field to talk to us about this, coming from someone who is trying to help our government and also help the hospitals and the systems to fight this little epidemic that we're having, and for us also in the diaspora to see how we can help, and those back home, how we can contribute to make sure that we can have access to basic sanitation and fight this little epidemics that are occurring all over Cameroon and also in Africa, in other sub-Saharan, also in West Africa. So Elvis, thank you very much.
Yeah, thank you. Obviously, we shall have the pleasure of discussing with Dr. Nicole Fouda. She's really doing great work across Africa, rushing into every country where there is cholera, and she's going to tell us a lot today. And of course, Mono, tell me, how do you really make it to be present in all these sessions? And most often these sessions happen when you had work with your patients. How do you manage this?
Okay, Elvis, today I'm actually moonlighting as an internist, but I usually go early. My residents are totally perplexed because they also go online on Facebook and watch me during this period. And in the ICU, I have a whole fan club. They are like, oh, there's this Cameroonian thing going on. In the ICU in my hospital, all the nurses know about this and they watch it. So each time I go there to see a consult in oncology, they're like, oh, we're watching you on Facebook Live. So it's amazing that others are interested in it. And they are getting to see that change can occur in Africa in different ways. So I've had others who want to emulate it in their different countries. And I just want to thank you guys for your time, for your sacrifice, and for the passion we both have. All the moderators, those are presenters who are coming in to put our own little effort in discussing healthcare problems in Cameroon and in Africa at large and the world, and see how we can get experts to look for solutions. And I think this is one of the forums that is bridging the gap between those in the diaspora and those back home, for us to better understand those in the diaspora and those in the diaspora to better understand the healthcare system in Cameroon. I found myself to have done both of them at different levels. So I do have the compassion for those who are back home sacrificing. And at times, I do not really love when people in the diaspora tend to belittle those who are back home who are sacrificing so much with so little resources. So I actually applaud them for staying and for doing what they're doing.
Thank you very much. Each time, one thinks of, choosing another competing priority on a Saturday, just the thought of your sacrifice, make us change our mind and try to be here all the time. Thank you for all what you're doing. And of course, We are still going to have other moderators. We have Brian Tegomo, who is going to be with us, and we have Therese and Zay, and of course, Alison is going to be with us too. And from time to time, they will dial in to say hello. So before we dive into the whole issue, I want to also just recognize some people who have already tuned in. I saw Dr. Alexis was already with us at the beginning. Kenji is there, Nancy Tamo, and all the other fervent participants of the Cameroon Town Hall. You're all welcome to this session. I'm sure many will be tuning in as we ride on. Of course, before we get to the presentation, I think we should get back to COVID and just know what is happening in the world of COVID. What are the updates that we can hear from our own Dr. Munoken? Over to you.
Elvis, thank you. I hope you guys are not getting tired of COVID. Well, I'm only going to paint a good picture. So today, as we said, we're going to have our own very expert from Cameroon, Dr. Nicole, who's going to talk to us about this very important topic. So before we get to that, I just want to tell everyone, at least we all know that COVID-19 is a battle of variants, it's a battle of where we're going to. So right now, we've left the Omicron BA.2, we're in the 0.2, 0.121, and 0.4 and 0.5, you have it a lot in Africa and in Europe. So this is just a cartoon depicting what the situation is right now, where we're heading to, and when we're going to get a new variant. I think it's going to come soon. I love this because we're trying to guess, we're trying to see what's going to happen in the world and what the next pandemic is going to be and when is it going to be and how we're going to be prepared for this. The good news is really that the number of deaths are actually reducing worldwide despite the number of cases staying up. So you can see here, here's a research. I thought wise sharing this because you can see that this was published in Science showing that dogs are able to identify COVID patients almost 98% accuracy in this research. So there's a lot we can do and learn from some of these animals. Here is just a paper showing exactly what we have learned throughout this pandemic. It's not just that we have had COVID. We've had COVID, but we've had the discovery of mRNA vaccines that we can use in other technologies and nanoparticles. So here are several vaccines that are under research and where we can also harness the technology that we have been using for messenger RNA vaccines. We can use it for the flu, Zika, HIV. There is a lot of research going on even in malaria, in rabies, Ebola, and some other viruses. So here you can see clinical trials that are on different levels of development, which shows to you that the future is going to be bright, especially for diseases like rabies and chikungunya, where we have little or no cure, and Zika, where we could actually develop treatment or vaccines for these particular elements. So here we just looked at the pandemic. I'm a cancer specialist, so I can tell you in oncology, this technology, we're using it right now in order to try to develop new oncology drugs. And in the US, actually, we do have the largest share of budget in order to deal with research. So we do a lot of research. So this technology is being harnessed also in oncology, and we're using it in melanomas, in non-small cell lung cancers, and also ovarian cancers, and also solid tumors overall. So here you can see that also the immunologists are trying to use this, and those in rheumatology are also using this technology. So this technology is going to be used throughout medicine. It's going to revolutionize medicine. So actually COVID was a good thing, but it led to a lot of developments, even in nanoparticle development. There are new generations of nanoparticles that are being developed right now. So this was just to share with you guys that COVID came in, but there are a lot of positive things that are coming with COVID. Going back to COVID, we're seeing that the BA.2.121 is being replaced by, is replacing all the other variants. And also the BA.4 and 5 is also, the cases are actually rising in the US, and they are having competing prevalence. So here you can see exactly the number of people who are infected in the US and all of globally as time goes by, the different pandemics over time. And here we see the different variants and their mutational profile. So are we done with this variant? There's always going to be a new variant. I think this is a disease that we're going to live with, Elvis. And you can see here that as much as we do still have immune compromised people, the world is not globally vaccinated. This virus has reservoirs in animals, and there's also co-infection and recombinant, so new variants are going to be formed. But the good news is that over time, we're going to have protection. What is sad about this is that a country like the US should not have had the number of deaths that we did have here. It shows that there is a weakness in the healthcare system and much has to be done. And here you can see that the pandemic is not yet over. Here is 2 months back in green, and here in red is now. We still have cases, but the good thing is we are not having the number of deaths for multiple reasons. And I would explain that to you very soon. So here you can see the number of daily new cases that are reported as of June 4th, that's yesterday. So as Brian would tell you, we are no longer testing a lot of people, and a lot of countries, including Cameroon, are no longer testing everyone. And so testing has become an issue, and people have home-based testing, antibody testing. So knowing the true prevalence and incidence of the disease is becoming very difficult. So sewage monitoring has become something very important. And a lot of epidemiologists would tell you exactly how this can be harnessed over time. We still have data showing us that those who are unvaccinated are the ones dying most. So please, if you can get yourself vaccinated, those who are back home, if you can get vaccinated, especially if you're in a risky group above 45 years old, you should get a vaccine. And those who are here in the third world, in the first world countries, in Europe and in the US, you should get yourself boosted. Now, there's always this controversy, do masks really work? A new study came out this week showing that masking actually works. And there is still controversy about what kind of mask. And I'm of the opinion that any mask does work, and we need to put on masks. That can be a debate for a whole session of the town hall and for a whole scientific meeting, even will not come to a conclusion. We do know that COVID has killed a lot of people. This is just in the US. There was a certain time the number of COVID deaths is actually above the number of cancer deaths and also above the number of heart failures. So we need to be very careful when we say COVID did not really kill people and it's a disease that was mild. It's getting milder, not because the virus itself is less virulent, it's because we're getting vaccinated and we've been infected before the immune system has seen COVID, so it's able to mount an accurate immune response. So children also do get COVID and they get infected and children die. So that's the rationale behind getting children vaccinated, especially those who are 5 to 11. We're still waiting for vaccines for those who are younger than 5. Here is the pandemic in the rest of the world. The reason why Africa was spared, we still don't know. No one can claim they do know the answer to that, but there are several postulations which I'm not going to discuss today. I think we've talked about this in the town hall and we can talk about this later. This is the prevalence of the virus right now in the US. We're having the BA 2.121, which is more prevalent, taking over from BA2. This is as of yesterday. So here you can see the different variants and exactly their characteristics compared to the BA1, which is the Omicron original variant. And you can see exactly how they respond to different modes of infection, mutation, and you can see the 3-dose vaccine and how efficacious it is. You can see that they're very efficacious against those who have gotten boosted. Here is just showing you exactly the number of different variants we have out there and the subvariants that are available and the different changes that have occurred in the genetic profile. Here's the mutational prevalence and still another mutational prevalence for those who are interested in this. So here we can see that over time, the BA4 and 5 took over South Africa, was more transmissible but less deadly. So it's a good sign, even if it takes over. If you're well vaccinated and also if you have good coverage, it's going to do well. Are we ever going to get to the finish line? I'm one of those who believe no. We have to learn to live with this, but we have to make reasonable decisions. So we do still need the switch cheese model in order to deal with this virus. And I think all of these strategies still hold. I think I presented this like 2 years ago, but these are strategies that we have to continue doing. Lockdown is going to be done limitedly and in limited circumstances, so we need to take care of that. But the rest of the strategies still are strategies that we need to use. Are we at the end of the road for masking? I think a lot of people are advocating against masks, but masks do work. They reduce other respiratory diseases, and we should wear them reasonably in areas that we do need. So what about the number of cases? We've had almost 500 million people have been infected officially with COVID, but we know this number is about twice the number we have here, or even 3 times. And we know that 11 billion people have received at least 1 shot of the vaccine. So 11 billion shots have been given out, 12 billion, just to say. And there is no vaccine that has been distributed as much as the COVID vaccine. So out of it, 12 billion, we do know the side effects. And if someone says they're doubting the side effects, then they don't know what they're talking about. This is the same information in Cameroon. Compared to 2 weeks ago, we have not had a lot of cases. We've just had about 200 new cases with just 3 new deaths as per the report, which I got from the WHO website. And here you can see the US also. And this just shows you how technology and science can be appreciated. The time it took us to get COVID vaccine, there is nothing as close to this. We've been waiting for HIV vaccine since 1983. We've been waiting for malaria vaccine since 1880. And finally, we got one. But so you can imagine how long and how much this is a big stride for science. So looking at the number of shots we've had, I said 12 billion. There is still the case I also updated for Cameroon. We still have very low level of vaccination in Cameroon. And most of those who have not been vaccinated are found in Africa. And this is very worrying in its sense. So we need to do much about this. Low-income countries. Here you can see that the distribution of vaccinated people really varies with the level of availability of financial help and aid the world needs. And also there was also discrepancy in the kind of vaccines they got. Most poor nations actually got vaccines that were less efficacious, and they could get only what they were given to. So we need to improve and work on enhancing our healthcare system to be able to do this. So looking at development, we have several clinical trials trying to look for a pan-viral vaccine, which the research center at the NIH at Walter Reed, a military center, is also having several trials at phase 2 going through this. We can see here that the 3rd dose vaccine is still efficacious and people should get them. And now we're even talking about a 4th dose. Here is just a 4th dose, especially for those who are 60 and above. It's now available in most countries in Europe. In Israel, it's actually available for everyone. And in the US, it's available. So please go get it if you're above 60 and prevent yourself from dying from COVID. It's really a shame if you die from COVID at this time. Now we can see that those who are unvaccinated are the majority of people who are still dying, but very soon when everyone gets vaccinated, then you start seeing vaccinated people die because there will be no unvaccinated people to die. So this can easily be misinterpreted in the literature. So here you can see that unvaccinated people are generally unprotected against COVID. This is the same data showing you exactly that a lot of people have come in contact with COVID. In the US, those who are 0 to 11 years, almost 75% of them have antibodies against COVID. So yeah, you can really see that a lot of us have gotten in contact and gotten infected. So this is just showing you that the variants are not gone. Other variants will be coming. Are we shedding ourselves? Are we ready for the next load of variants? When are we going to have a pi? Is it going to be called pi, rho, or stigma, or sigma? I don't know exactly. Will the world still shut down the way they did for South Africa? Is Africa ready with its cold chain in order to preserve these vaccines? I think we are in really a terrible time where we've had a vaccine, but there is also difficulty preserving it, and we are not improving the technology behind it. Our dream vaccine, when are we going to get it? Where we'll have a vaccine that is going to work for everything. So really, going into therapeutics, I'm not going to waste your time here. I think we did talk about this last time. We do have, for those who are not yet very sick, we have some strong evidence that we have Paxlovid, which is FDA has an emergency use authorization, Monopiravir. We have Remdesivir for those who are not yet sick. And we also have monoclonal antibodies. For those who are severely sick, we do have corticosteroids, interleukin-6 inhibitors such as tocilizumab and baricitinib, which is a JAK2 inhibitor. So here is just for anyone who is interested. It's important for us to know that ivermectin did not work, hydroxychloroquine did not work, antiretroviral medications for HIV did not really work. So here is the prescription. Those who want my slides, I can share them with you. If you have COVID patients and you want to know exactly what amount of dexamethasone corresponds to prednisone, corresponds to methylprednisone or hydrocortisone, I can send you that. If you do have tocilizumab, it's a very expensive drug. We use it in oncology in order to treat cytokine storm in patients who get CAR T cells, but it's also used in COVID in situations where they have high inflammatory markers. We also do use baricitinib. This is actually available back home in Africa, and you can get it. It's a rheumatological medication, and the company has made it available. So we do have, here is monopera, it's Paxlovid, which, and how you give it is given twice a day for 5 days. There is also the rebound phenomenon, which has been discussed in the media, where those who took Paxlovid later on develop COVID signs after 5 days of completing the dose. But there is a lot of research going on, but we don't know if this is attributed to Paxlovid or is just attributed to the virus itself. So here you can see the efficacy of Paxlovid compared to molnupiravir. Paxlovid is very efficacious, almost 90% reduction in mortality. Here is the mechanism of action. And these are other drugs that we spoke about. Remdesivir, it was approved for severe disease, but it really works in mild disease. And here you can get 3 doses in the outpatient. So these are monoclonal antibodies. Evershell is a drug we use, especially in oncology patients. Those who have weak immune system, it can protect you against COVID for 6 months. So we do give this to a lot of our cancer patients. So here you can see that ivermectin is not approved, it's not efficacious, and so should not be used because we have other tools that are available right now. So just as a summary, these are the drugs that are available and the things you can use. And we're advocating that these drugs be made available to Africa in case we have an upsurge of the pandemic. So not to waste your time, this is all what we have. And we just need to make sure that we have a Swiss cheese respiratory virus pandemic defense system where we put all of these things to action. Not forgetting monkeypox. I think one of these days we're going to get back into this. Elvis, I added this in the slides just to make sure that we know that there's a zoonotic disease going out there. It's actually one of those diseases. Those who are in Africa know about this. Those who have been in healthcare, but it's strange because Cameroon actually acts as a bridge between the 2 subtypes, the Central African type and the West African type, where you do have, these are the countries prior to this spread right now. We know that locally acquired, you do have monkeypox in Cameroon. Several cases have been reported. This is prior to 2001. These were the number of cases that were reported in different countries. Most of them were imported to Europe. But here you can see that the cases actually exist in Central and West Africa. And you can see from this graph the different areas where you do have cases. So there is actually the West African group, and there is also the Central African group of diseases which are they are somehow subspecies of each other. Mortality also varies from one species to the other for the monkeypox. So transmission is usually from animals to humans, and you can also get it from contamination of eating food, which is not well cooked. You can also get human to human, and women who are pregnant can get it. So it's important for us to know that the major respiratory and contact precautions need to be taken, and we need to raise awareness and also start discussing other things to prevent this. So these are the different things you can do. Here we do have monkeypox is becoming part of the news because we have cases in the US, in Europe. So anything that actually affects the first world countries, the developed world, becomes a problem, even though we've had it in Africa for a while. Here are some of the countries that actually had cases 2 weeks ago. There are more countries. So thank you very much. I think the house is now full. We can go and start our session. Thank you. And welcome everyone for this wonderful session today.
Wow. Thank you very much, Dr. Monaken. I don't know how we would have done without you getting all these updates and this really incredible work you do every week to put together this summaries of updates on COVID-19. And one of the things I'm happy is I was waiting to see if at the end of your presentation for monkeypox, you will only end with the image of a black man with the monkeypox. I'm happy at least you showed the image of a white man with it, because it's become a kind of an illness that is also being racist in kind of way. All the images I've seen on CNN, on most of the major medias in the United States and across the world, they only show the black skin having monkeypox. But I think it's just clear that it affects everybody, even if there is a historical evidence of that it affected Black people more, but now it's a global issue and we should have to face it the way you have just done the presentation. Thank you very much. Brian, welcome to the session, and I know you were here at the beginning. How are you today?
Yeah, I'm doing well. I think that's a really great summary of what's going on globally on emerging infectious diseases in general. That was really a great summary, Dr. Foma, and thanks a lot for sharing all those details. I think that was very useful. And I'm really excited about the presentation today because we again talking about another disease that has epidemic potential, which is cholera. And I'm really looking forward to this discussion.
I'm very excited. Each time I see you, there's one word that comes into my mind: genomic sequencing. That words come out of you all the time because your work is just about, trying to trace issues and find out where they are coming from, sequencing and all that. I'm sure you have a lot to tell us with what, is happening as far as cholera is concerned as well. So we had Teresia. Teresia, I know you're very busy, maybe somewhere driving, but we always want to just see your beautiful face in the town hall. Hi, Teresia. Teresia is not available. Is Allison there? Okay, just checking to know some of the moderators if they have already tuned in. To Christelle, I hand over to you to present our speaker for today.
Thank you, Elvis. Hello, everyone. Welcome once more to this new edition. So I have the pleasure to present our special guest of today. She's one of the proud medical doctors of our field, and then she's among the best experts to talk about this topic today. So Dr. Nicole Fouda Mbarga is a consultant epidemiologist and focal point of cholera control at the World Health Organization. She's a dynamic medical doctor and public health analyst and researcher. She has various skills, among which public health, disease surveillance, community development, through public health initiatives. Her research interests are sickle cell, global health, gender equality in global health, and many others. She's a strong advocate of gender equality in global health. She's a medical doctor from University of Buea, where she graduated. After her studies, she moved on to Ghana to learn through the yearly program, Management and Public Administration. Furthermore, she went through the Glasgow Caledonian University, where through the Afiabora Fellowship, she owned a master's degree in public health. She has been occupying several positions at various organizations. First, she was Deputy Incident Manager for Cholera and Incident Management System for WHO. Later on, she occupied positions such as epidemiologist at Alima Foundation, Doctors Without Borders. And then she has various research papers out there. I'll share in the chat a link to the social media, where she published several studies from cross-sectional studies, systematic review, meta-analysis. And also she has several voluntary activities. I can just name some with the Michael and Mauricia Pacha Foundation. And also as a leader, she also occupied the vice president position of all the UB Alumni Association. So Dr. Fouda is mostly highly welcome today in our field. We are proud of her. We are happy she could make time for us. And we are looking forward to learn from her experience in cholera management in our setting and in all the different settings she has been working through. Thank you, Dr. Nicole Fouda Mbarga, for accepting our invitation today. I hope to have been faithful with your presentation. Thank you once more.
Over to you, Doctor. We've heard, and that's what an amazing resume you have. The floor is yours. Take it away from me. You might want to unmute yourself. Okay.
Hi, everyone. Thank you so much for inviting me today. It's really a pleasure and a privilege, and I'm happy to share with you my experience. So thank you, Christelle and everyone. Can you hear me well? I'm actually in Niamey, and the connection is not so good. So I'm just wondering.
We can hear you perfectly.
All right. So I would like to present my screen, to share my screen with you. Let me. Okay.
Yes, we can see your screen.
All right, thank you. So the topic of today is cholera epidemic in Cameroon, and we are going to talk about experiences and the lessons learned. So I'm Dr. Nicole Fouda. I don't need to present myself again. Thank you, Christelle, for the wonderful introduction. All right. So the plan, we are going to take a look at the background of cholera. We are going to talk a bit about the history of cholera in Cameroon. I'm going to present the current situation of cholera in Cameroon, talking about the epidemiology, the risk factors, the public health response, what has the government done, the challenges, the perspectives, and I hope that we can have a discussion about how we can all support the country. I know that there's a lot of diaspora here. So just to start, you know that cholera is an acute diarrheal disease, and it can be very fatal if not treated. Actually, in settings where you have a good treatment, the case fatality rate should be less than 1%. It is caused by a bacteria called Vibrio cholerae, so it's an infectious disease, and it's a foodborne disease which can be gotten from contaminated water or food. So about 1 million to 4 million cases are reported yearly, with about 20,000 to 143,000 cholera deaths yearly, according to the WHO. But the burden is really underestimated because, of course, it depends on the surveillance capacity of countries. But we know that most of the people having cholera live in Africa, about 40 to 80 millions of people. So it actually reflects poverty and poor investment in water, sanitation, and hygiene. So you should also know that there's a global strategy for cholera elimination that was launched in 2017 by the Global Task Force for Cholera Control, and it targets 47 countries. Actually, the objective is to reduce cholera deaths by 90%, and Cameroon is among the countries that should be doing that. So for the history of cholera in Cameroon, cholera started in Cameroon about in 1971, and Cameroon is really among several countries in West and Central Africa, always having recurrent cholera outbreaks. So it's endemic in Cameroon. The worst outbreak was in 2011, when the country reported more than 23,000 cases and more than 800 deaths. But we observed a decreased occurrence between 2014 and 2017. But since 2018, Cameroon has experienced recurrent cholera outbreaks, and the current outbreak was declared towards ending October. So for the current epidemiologic, the current epidemiologic situation of cholera in Cameroon, the source is the National Situational Report in Cameroon. So we currently have 31 districts that are affected in 7 regions of the country, 7 regions on 10 for those who know Cameroon. 7 regions have reported at least 1 case, confirmed case of cholera. So you have the Southwest, which is of course the epicenter of the outbreak, so the most affected region. You have Littoral, which is the second most affected region. You have the South, you have the center, the West, the far North, the North. And currently 4 regions are active. As you can see on this map that was developed by the country, you see that in red, you have the regions that are currently active, like the South, the Littoral, the Southwest, which of course has most of the cases. You have the West region, then you move to the North, and then the far North. And the regions that are colored in yellow are the ones that had been active in the past. So far, only 18, not only, but 18 districts are currently active. 8,135 suspected cases have been reported by the country, among which 461 were confirmed by culture, which makes a percentage of 5.9%. And we know that the WHO standard requires an outbreak to have at least 8% of confirmed cases, but we are getting there gradually. We are coming from far, but a lot of efforts are being done by the country. So far, 151 deaths have been reported, and the case fatality rate is 1.9%. And I would like to say that this is it has improved, because at the beginning of the outbreak, we had our percentages like 15% in Southwest, in Bakassi, for instance. The median age of cases is 25. At the beginning, more males were affected than females, but now we see that more females are affected. So the summary by region, you have the Southwest, which is the epicenter and has notified more than 75% of all the cases, with a total of 5,533 cases and most of the deaths, of course, and then followed by Littoral, and then the South, the North, the Far North, and the West, which are recently entered into an outbreak. And this is the global epidemic curve of the country, and it's the source is the National Situational Report. Of course, we can observe that from the beginning last year, we had very few cases, and then we had a serious peak around the 12th epidemiologic week this year. And gradually, with the interventions being put in place by the country and with support of the partners, we see that there's a decrease, but we are not yet there. We are not yet there. So the risk is still there, and the outbreak is extending. It's spreading, sorry, to other regions. So globally, we can see that most of the people affected are aged 21 to 30 years. And most of the cases are moderate, but 32% of cases are severe, which is quite high. So what are the risk factors for cholera in Cameroon? On the right, you can see it is really clear. There's limited access to safe drinking water in some areas. You can see some people still going to streams to fetch for water. And besides, there are other people still doing their excreta in water. So it's really, really tricky. We also know that there's a seasonal pattern for cholera occurrence in Cameroon. In some regions, you have it most often when there's rain, and in some regions when it gets really dry. We also know that there's inadequate water, sanitation, and hygiene conditions. There's a humanitarian crisis affecting more than 4 regions of the country, including the Anglophone regions, the Far North with the Logon and Chari crisis. And we also have in the East, a lot of refugees that are from the Central Republic of Africa. So all of this make the population a bit vulnerable, because these people tend to live in poor water, sanitation, and hygiene. So we also have cross-border transmission from countries like Nigeria. We know that Nigeria last year experienced a very hard cholera outbreak. And in Cameroon, actually, the index case in the Southwest was a Nigerian fisherman. So there's really, really an important cross-border transmission between the two countries. So on this picture, you can see a water source in the district of M.Sc in Yaoundé, the capital. It was really shocking, but it happens. And beside this water source, which is really used by many people in the Quarter, you have a dumping site for waste. So it's really a tricky situation. So what has been done so far by the country? In terms of coordination, the country activated a national and regional incident management systems to sort of manage the outbreak, and they hold regular coordination meetings with partners. There has been a response plan developed by the partners with, by the government with partners. There have been advocacy meetings which are conducted regularly, locally, and with international partners. In terms of case management, surveillance, and laboratory, There have been provision of cholera kits for management and also for diagnosis, and treatment centers have been set up, although it's still needed. Response teams have been deployed to major outbreak sites, and investigations have been conducted to sort of understand what is happening and so on to inform the response. Surveillance activities have been strengthened for active case finding and patient referrals. In terms of immunization, the country has conducted a first round of mass vaccination campaign in 15 health districts in the Southwest, Littoral, and the South. And also a prison was affected and mass chemoprophylaxis was done with immunization of all the prison, and the coverage was good. In terms of risk communication, community engagement, and also WASH, there has been decontamination of sites where cases are registered. Community members and leaders have been trained on hand washing, water purification, disinfection of homes and public spaces. There have been improvement of some water sources and also water trekking, but you know that water trekking can be very, very expensive. That was done in Bakassi, and it's not really sustainable because, you know, Bakassi is an island, and the outbreak started in those islands of the Southwest and gradually moved to the, how do they say, to the terrestrial area. So from the islands to the terrestrial areas. So there are a lot of challenges really threatening the response in Cameroon. First, the security challenges, especially in the Anglophone regions. It has been really, really tricky to do surveillance, to even detect cases, to confirm cases, to do management, to set up a real response in that context. Now the outbreak is really widespread with 7 regions on 10 affected. So it makes it really challenging because you need the funding, you need the human resource, you need the materials, you need people that are really there and devoted. But of course, it's not the only public health challenge in Cameroon. You still have other health emergencies like yellow fever, you have polio, you have COVID-19, although it is getting less serious. So the same people are at the forefront. So it's really, really challenging. And also we have new hotspots with limited response capacity, like the West region was not used to having cholera cases, but now the West region entered into an outbreak since a few weeks. We have insufficient multi-sectoral collaboration because the Ministry of Public Health is still the sole ministry at the forefront. And we know that cholera is a problem of water and sanitation, and the action conducted by other ministries like the Ministry of Water are not so visible. The collaboration is still really much needed, insufficient. There is insufficient investment in WASH intervention. We don't see a lot of water sources improved or toilets being constructed for the population. Insufficient human resources. The same people are at the forefront leading the response for other health emergencies. We have inadequate community engagement. We still see children having to, not only children, even the population still defecate in some water sources being used by the same population. We have a limited vaccine stock. There's limited funding for WASH infrastructure, but for the response globally. And we can cite many more challenges. But the good news is that there are some interesting perspectives going on in terms of preparedness and response. So the country is aiming to develop a national cholera plan. And the objective of this plan is to eliminate cholera by 2030. And we know that this is possible because Haiti has done it. The Republic of Haiti is now free of cholera. So the plan is to conduct a high-level advocacy meeting to increase multi-sectoral collaboration. to do more resource mobilization, more in terms of research. And I'm happy that Brian is here because there are also some research perspectives in terms of genomics. Investment on WASH infrastructures, preventive immunization, because we know that immunization against cholera is also a way to protect the population. When 2 rounds of doses are received by the population, they can be protected for 3 to 5 years. And this gives time to actually invest on other pillars of the response, like water, sanitation, and hygiene infrastructures. The aim is also to train emergency medical teams and rapid response teams. So these are just a few things that the country is aiming anyway, where the country is trying to reinforce the preparedness and the response. And we really count on all of you to support the country. So thank you very much for giving me the floor. And I would like for all of us to now discuss, reflect on what is happening, and how we can improve the response, and what is the role of the diaspora. Thank you very much.
Many thanks, Dr. Fouda, for your presentation. We had many insights. Already in the chat, we have some comments and questions. And as you rightly said, it's time for discussions and on how we can improve the situation in our country. So in the chat, I can start with the comments I received in the chat. Sorry, I cannot on my camera because we don't have light now. You just cut the light, but I will just be reading the questions from the chat.
Okay, if we can ask Dr. Fouda to stop sharing her screen, that would be nice.
Okay. Dr. Fouda, please, can you?
Sorry, I didn't hear you well, sorry.
Yeah, just please, can you just stop sharing your slides so that we proceed with the question and discussion session? Thanks. Okay, in the chat, we have some few questions and comments. I will proceed with that while waiting everyone to either raise their hand to have the floor to ask the questions. I will start with Mr. Kwan Jacob. He's a common participant of the Cameroon Town Hall. I don't know whether do you want to express yourself and unmute to ask your comment or question? Yes, thank you.
Thank you, Doc. Good evening to everyone. I want to appreciate Dr. Nicole for giving us this update. As you said, I am Kwan Jacob, and I'm a nurse by training, and my area of interest is IPC WASH. I also hold a master's degree in public health. The issue about cholera actually are far from just looking at cholera itself. We really have to look at the setup, and I think our setup really has very little emphasis on the public health component, which is actually responsible for preventing epidemics like this one. Most of the communities do not have water. You remember sometime before, I think 82 or so, we used to have sanitary inspectors who used to go from village to village, and you hardly will find a compound that did not have a toilet. But now it is very common to find a household without toilets. And in some of the communities, they practice open defecation in the stream that are also used to carry water for house needs. And it doesn't seem to bother anybody. The present policy says that it is the council that is responsible for some of those hygiene and sanitation initiatives. But if you go to the council, you really do not have to go beyond the council. I mean, most of the cholera outbreak, they are coming from those communities where they do not have clean water and where some of the households do not have toilets. And it doesn't really seem to bother anybody. So if we have to prevent outbreaks, cholera outbreak in Cameroon, the first thing is to strengthen our public health system to be able to educate the community on hygiene and sanitation initiatives. And then concerning the present outbreak, it took very long time for government to launch the response. And when speaking in French, and the community could not understand what they were talking about. And when you ask yourself, what kind of response is that? When something begins small, if we engage well, we will stop it while it is still small. And then when we delay, it spread, and then we end up spending more. And that is really a problem. I really feel a little bit very worried about the way the response really was, because I don't think that cholera is not a new infection in Cameroon, and we should not respond as if it's something we have never known. Of course, there are fundamental reasons, and some of the reason is that I suspect, I'm saying I suspect because I am not part of on the frontline team. I suspect that the resources that we needed to respond are not there, and that is the reason why we actually delayed. And then some of the frontline team members, they expressed a lot of dissatisfaction about.
Yeah, Jacob, thanks a lot, and thanks a lot. We have some difficulties getting you, Jacob.
That they don't have resources to do what they are supposed to do. Even I don't know whether the situation has changed now, but as at last month, most of the response teams did not have sufficient.
Jacob, really appreciate it if you can keep your comments really short. And if you can keep your comments really short and to the point, I think that would be very helpful for everybody. Thanks a lot for those comments, and really appreciate it. And if you can keep your comments or questions really short, that would be really helpful.
Yeah, thank you, Mr. Jacob, for your comments. I don't know whether Dr. Fouda, do you want to react on some few points Mr. Jacob raised?
Okay, thank you very much. Let me just react to that. Actually, when the outbreak started in late October, the country was also preparing AFCON, which is the African Football Cup of Nations. And like I said, the same people are at the forefront of all of this. And so it's really tricky. Like the same people have to manage yellow fever outbreaks, polio outbreaks, AFCON being put in place, cholera being put in place. It's a lot for them. It's not easy. Like myself, I used to say, the response was maybe set up later, but at the local level, it was not later. And I assume that the region has some independence. So I wouldn't say the response started later. But the challenge with the Southwest region is that the outbreak started in insular areas. Areas like districts like Bakassi, Ekondotiti, Mundemba, and the rest. And it was really tricky, even getting there. Transportation was a problem. Telecommunication was a problem. Getting the data was a problem. Confirming the outbreak was a problem because Southwest at that time did not even have a laboratory that can confirm cholera. Samples had to be taken to Littoral. It was really challenging. And we can see it from far, like a response that was delayed, but it was really challenging. You know, people had to travel by boat and paying, I mean, sums like 300,000 to get to Bakassi and the rest. And it was really challenging for the region. I'm happy that the delegate is here and I can see him, because I know how it could have been complex for them. People can just say, yeah, they can look from far and say the response was implemented with delays and so on. But it was really tricky for all of them. And I really want to applaud them for even setting up a response in such a complex situation, because we know that now Bakassi and the rest are a bit free from cholera these days, at least for more than 90 days. We haven't had cases in insular areas. So the problem now are these other areas. So yes, it was delayed, but then it was really complex. It was not that easy. You know, the Southwest experienced security challenges, and so it really makes the response complex. Thank you.
Thank you very much, Dr. Nicole, for your answer. We are happy to have the delegate among us, and we hope to have his comments or questions or contributions along the way. As we are waiting his reaction, I have a question in the chat from Skyner. So Dr. Fouda, do you think, can you give an explanation for the fact that people aged 21 to 30 were the more affected during this cholera epidemic? You are
Well,
muted.
if I may provide an answer, we can just provide hypotheses, because to be sure, we probably have to conduct some research. Perhaps as a hypothesis is that most of the population could be aged around 20 to 30. And probably those are the people really exposed to contaminated water and food. So those are some of the hypotheses I can think about. The proportion of the population in Cameroon is younger. So that could be one reason why we see that most of the people affected are age 21 to 30, the younger people. So those are some hypotheses, and I leave the floor to other people to try to provide hypotheses. We also know that fishermen were affected. So perhaps the working class people that were fishermen could have been aged 21 to 30 years. But again, to verify all these hypotheses, we need to do more research or to analyze data. Thank you.
Yeah, thanks a lot, Dr. Fouda, for that response. When we go out in the field to do or to carry out epidemiologic outbreak investigations, we just report what we see. We don't to respond to Skinny's question, we just report what we see. We don't hypothesize, we don't postulate, we just report what we see. And sometimes we may see that there's an increase in some people, of a specific age group or demographic having, that's similar to what we are seeing with the monkeypox outbreak. I think there's been increasing reports of people in the MSM community having more, being more affected. That doesn't mean that the virus is necessarily exploiting a new route of transmission, but it just it's just a report, an epidemiologic observation of what's being done. But I completely agree with Dr. Fouda that we need to do some more thorough studies to pinpoint what the cause might be and what might be driving that specific demographic.
Yeah, thank you. Thank you, Brian. We see the comments from epidemiologists coming in from various sides. Dr. Fai in the chat, Dr. Fouda, Brian, thank you very much. So may I please call on Mr. the Delegate to give some comments about on the current discussion, if he's not asking too much. Thank you so much. Mr. the Delegate, if you're speaking, your mic is still muted. Okay, while we are waiting on the delegate, let me give the floor to those who start raising their hands. So I'll call on Jane. So please, can you present yourself? I know some might know you, but no, that's not. So where you are joining from, and then ask your question. Please just be brief so that we have the floor for each one to ask his own questions or comment. Thank you. The floor is yours. Yeah, you're still muted.
I think it's Dr. Judwin was showing up
I'm
as
sorry.
Jane.
That is
Yeah, from UK. Thank you. Thank you. Go ahead.
Anyway, I'm Judwin. Nice to meet you all again. So I'm Judwin. I'm a pediatrician. I'm also a nutritionist based in the UK. So my question to Nicole is about. I think Jacob mentioned it really about the underlying problem, the underlying cause of cholera. Obviously, I know that there's a rapid response when there's an epidemic and outbreaks, but what is the long-term plan? Obviously, it's providing toilets and access to water. So what's the long-term plan? Are there budgets? Are there things in place to, start ensuring that these things happen? Or, are we just waiting for the next outbreak to happen again? Thank you.
Thank you, Dr. Jutwin. Thank you for always tuning in every fortnight. Dr. Nicole, do you want to respond, or do you prefer we take like two questions before you respond, or you go through?
Yes, please. But Judwin was cut while she was talking. Maybe my network, so I didn't get the end of the question. Sorry.
That's fine, Nicole. I can say it all over. So my question was regarding the underlying cause of cholera. Because I said, obviously, we have the rapid responders, the people when we have the outbreaks, and a lot of funds get mobilized when there are outbreaks. Obviously, I've worked with M.Sc, so I kind of, and when there was a cholera outbreak when I worked with the Central African Republic crisis. So my question is, what is the underlying solution? Obviously, is providing access to water and toilets, sanitation, hygiene. If we don't have those, we're going to keep having this outbreak. But I'm sure everybody knows that. But what is the plan? Is the government now mobilizing funds and things to make sure this is done? Or, what's the long-term plan to get, to solve the problem of cholera? That's my question.
Okay, thank you, Dr. Judwin, for the question. So like I said, the response is there, but it's mostly focused on the Ministry of Health with little contribution from other ministries. Like Ministry of Health is there to make sure people don't die, like trying to put the fire down, to stop the fire. But the Ministry of Health cannot continue to struggle alone. Other people have to take their responsibility. The toilets and the water sources have to get improved by others. And so this is why the Ministry of Health is taking actions in collaboration with the Prime Ministry, with the hierarchy, to set up an advocacy for others to join and to take their own responsibility and to start improving the water sources and building toilets and etc. It's a long-term investment. It's a development project. Unfortunately, it's costly to build toilets and to improve water sources, but it can be done if there's coordination, if there's collaboration, if there is investment, if people come to understand that it is necessary. And also, I believe that it can also be done at our own local level. For instance, if I go to my village and I see that people are still drinking water from a stream, what is my responsibility? We have mayors, we have councillors, we have governors. What can they do about that? Are we only waiting for the Ministry of Health to intervene? Because that's not their mandate. I mean, they are there to save the people, but other people should join and take their responsibility, because cholera is—
Sorry, that is the mandate of the Ministry of Health.
No, I think it's housing and town planning. There's a Ministry of Town Planning, right?
Exactly.
That's their responsibility to make sure, because if the houses are not well planned, then you have houses built with no room for toilets, pipes to pass through. So that's the Ministry of Housing or it's urban planning or town planning, something of the sort, isn't it?
That's right.
It's even the Ministry of Commerce as well. If the Ministry of Commerce can make sure that nobody opens a bar without a very good toilet where people can even ease themselves, and that businesses have, at least you go to Cameroon, sometimes you stop at the filling station, the gas station, there's no toilet. I mean, every business, those basic things, if toilets and all this basic running water can be just some basic things that even the Ministry of Commerce inspects for every business setup. So it's a kind of collaborative effort, interministerial, intersectorial effort to really fight this battle. Yes, Nicole, you can go ahead. Hi, Nicole.
Hello.
Yes, Doc, we get you.
Yeah, I didn't get the question. I'm sorry, but I intervened to Judwin's comments. But the last question, I'm sorry, I'm breaking off from the connection.
Okay, sorry, it wasn't a question. I was just adding to the fact that this entails more of intersectorial, interministerial collaboration, because even the Ministry of Commerce has to ensure that businesses have running water, toilets, and that this has to be inspected, and every other ministry is involved. Schools, secondary education have to make sure that primary schools have toilets and running water for kids to be able to wash their hands and go to decent toilets. Ministry of Transport has to make sure that all agencies have toilets that are free, not that you go to a moment in the night and you want to travel, they ask you to pay 50 francs before you go to the toilet. There are some basic amenities that every sector has to ensure that those dealing with or doing business in that sector have to meet those standards. And if we look at it from this interministerial collaboration approach, with the lead being the Ministry of Public Health, then I think we can actually really achieve more together.
Thank you very much. That is right. And that is where the country is aiming at. And we really hope that within the shortest week coming, we can see that the country is actually planning a high-level advocacy meeting, inviting all of these stakeholders. And we hope to see that happen in the next month. Thank you.
Great.
Thank you. Thank you for all the comments and responses. So I see, Herwin, you posted a question in the chat. Do you want to, and then you raise your hand? Do you want to express yourself? I know you have lower your hand. Herwin Baudouin. Sorry
hello,
if I
everyone.
But yeah, hello.
Yes,
Please, can you present yourself?
Thank you.
Okay.
Thank you. My name is Erin Bodo. I'm a data manager. Now contract with Doctor Without Borders, and I'm also a member of IR Consortium. I'll just hand my hand up just for my question. It was about the strategy of catching cholera leading last year by Dr. Nicole. I know it was very successful as far as so many articles come from that is concerned. So my question was about that. What about the expectation of this strategy? Have there anything about periodization around this strategy? What was the challenges, the difficulties? And because I was thinking this strategy is it any issue about that strategy to maybe eradicate cholera? Can it be possible using that strategy? And if not, what are the main challenges? That was my question.
Okay, thank you. I'm going to take that. Yes, CATI, which refers to case area target interventions for cholera, was done in Kribi in 2020, if I remember well. And it worked because it occurred as a complementary package to what was already done. So those were interventions around cases to limit the spread of the disease. But CATI really includes things like health promotion, WASH interventions, immunization, community engagement and risk communication, everything, but really centered around cases in the vicinity of the cases, like from 150 to 250 meters. And the issue with CATI is that you need the vaccines as well. But currently, the mechanism through which Gavi gives the vaccine does not really give room for CATI to be implemented with a lot of doses. So Gavi is mainly for mass vaccination, although sometimes they accept CATI, but the extent to which they accept CATI is very tight. So it limits the country in terms of operationalization of such interventions. But again, we are still trying to advocate for CATI to be implemented. We know that NGOs like Doctors Without Borders are really good at implementing such strategies. And so there's a lot of advocacy being done. We've seen CATI work in countries like DRC, the Democratic Republic of Congo, and even Nigeria. And then we hope that at this point in time, CATI can be done, especially in regions experiencing a really small outbreak, like the West. CATI can be done there to really circumscribe the outbreak so it doesn't get to other districts. We know that 2 districts are affected so far. If interventions can be done around these districts, like circling them to really contain the outbreak as soon as possible, it would be great. But the issue with CATI is that it requires a lot of funding and human resources. It consumes, it requires a lot of funding of materials like the aquatabs to use to decontaminate homes, vaccines, sometimes chemoprophylaxis, especially in homes of cases. So it's really a tricky situation. So it's becoming complex because the country has a lot of outbreak sites, and yeah, it's really tricky. We need not just one approach, but many approaches now to get rid of the outbreak. There's no magic solution at this point in time. We need quite some solutions now. Thank you.
Thank you, Doc. Thank you for your response. So I'll give the floor to Joel. Joel, you have a question in the chat about, you have missed the etymological definition of CATI when Dr. Fouda speak about earlier, but I guess you have also another question. Please go ahead, present yourself, where you are calling from, and ask your question. Thank you.
Thanks very much. My name is Joel Duntio, and I work on community engagement with an NGO called Treatment Action Group based in New York. I'm based in the USA. So I think mine was more of a comment, and I'm happy that Elvis came in to address part of it, which was that all of these issues we're discussing are solely the responsibility of the Ministry of Health, the MOH, and that the MOH cannot, of course, work in a siloed manner. It has to work in collaboration with other ministries to ensure that there is, in any of the related ministries, someone from the MOH who ensures that basic hygiene and sanitary measures are put in place to ensure that public health concerns are preempted and addressed before they even arise. So I just wanted to also find out, the delegate which you mentioned is or was on the call. I think it will be interesting for us to know which delegate is that, what's their name, so we can know what to ask them, because I think it's important to know if there are people working on law and policy in the call, just for them to tell us why is it that these snack bars, agencies, and restaurants don't have toilets? Why do we not have toilets in those public places? Thank you.
Thank you. Thank you very much for your comments. So yes, maybe we take a break while Dr. Nicole is taking a cup of water. First, to take the temperature in the room. It's getting hot. Let us put a bit pause and take some temperature before you respond to your question. And maybe call on Dr. Ivo Dita, who is the delegate, to respond in a later stage. But before he prepared his response, let me call on some participants to have their thoughts about what is going on now. Nancy Tamo, may I please ask you to unmute and tell us how do you feel about this session? What do you think? Nancy?
Yeah, thank you for putting me on the spot. Yeah, I just feel like first that I really enjoyed this. Is my second session so far. I'm grateful to be here. And really my thought is, as much as we have like ideals of how the government should act interministerially, my thought is just to know, I'm a student and still developing my career. My thought is just to know, as far as experts are concerned, you guys, what can we really do? Because we have really said, I think the government knows exactly what they need to do, but they don't do it. So at the local level, what are your actions? At individual level, your very local level, because I've sensed like there was some kind of argument at some point about what the government or the health ministry has to do. I think they know all those things, but what is our contribution, knowing that they don't do what they do? What can we do really?
Okay, Nancy, thank you for joining us for more than once. We are happy to have you among us, and we hope you keep on turning in for future session. So your question is taken, and let me take another person's point of view about the current session. Belize Ngum. Hello.
Yes, hi, good evening, everybody. I'm Belize Ngum, public health physician working with UNICEF, Yaoundé country office. Unfortunately, I joined the meeting at the session just some few minutes ago, so I was not able to follow what was presented. Nevertheless, we're all preoccupied by this situation of cholera, the cholera epidemic, especially in the Southwest region, and we're giving our support to the Ministry of Health so that, yeah, the cholera can be controlled, yeah, contained. And thank you. I usually join, but sometimes late, and I hope I'll be able to be more regular, and maybe why not present something? Yeah, okay. Over, thanks.
Very good. Thank you so much. We are happy to have you, and we definitely contact you to learn from you, from your experience at UNICEF and other programs you are running or working in. Thank you so much for joining us today, and we are happy to have you among us. So maybe the last call will be Forty Luis. Can we please hear your voice?
Wow. Yeah, thank you. I think it was quite an interesting presentation. Well, what is quite depressing is that we'll keep hearing these stories, or next time will be another outbreak. I think we should, what I would like to say is that it will be interesting for us to kind of focus on long-term plan. Because what I'm saying is that we are more focused on reacting to situation. We are not proactive. So what is going on to me is just, hello, can you hear me?
Yes, please go ahead.
Yeah, what is going on to me is, I don't think it's the right approach, because we're just reacting to something that happened. It will be more interesting to look at long-term plans. So that's like, I would like to have Dr. Fouda's opinion on this. Are there strategies being put in place to really look at long-term plans to kind of contain this? Because what is happening to me is just like that, just mainly spraying perfume on excreta, because in a couple of months we'll have another outbreak for sure elsewhere. So we should kind of focus on long-term plans. Yeah, I forgot to say I'm calling in from Canada. I'm a scientific evaluator with Health Canada, the Bureau of Non-Prescription Drug. Thank you.
Thank you so much for giving us your opinion, for dialing in, and we hope to have you in the next sessions. So having taken some point of view and comments, may I please call on the delegate? I earlier made a mistake. I apologize. Can please Dr. Echo, Christelle, give her comments on the current discussion, the cholera outbreak?
Yeah, just
and also, if your mistake was a good one, it would always be a very great pleasure to hear the voice of our own Dr. Dieter Ivor. He is here, and we should hear his voice after Echo speaks.
Yeah, so I want to start by thanking the delegate. I never knew the delegate was going to make it here. So thanking the delegate for coming, and Dr. Echo, it's a pleasure, please, for really coming to discuss on this platform. We are a platform, the Cameroon Town Hall for Healthcare Professionals includes Cameroonians at home and abroad, both English speaking and French speaking. Christelle has been talking in English today, but she's actually French speaking and very bilingual. I don't know why she didn't talk in French.
English,
if she has to pay a fine for just speaking only in English, English and French speaking, very bilingual. And please, you are welcome to the town hall. It's where we really discuss issues that we're facing back home in Cameroon and try to find solutions and try to build on the strength of each other. Also try to galvanize the diaspora to be able to see where they can help back home. And also those who are back home to see how they can collaborate with the diaspora and teach the diaspora what exactly they're doing. We can learn from those who are back home. We have learned a lot from COVID. We have learned a lot from malaria. We have learned a lot from several things. So it's more of a platform for collaboration. And please, you are very welcome to this platform. So you have the floor and we are honored to have you.
We are expecting to hear Dr. Echo, or is the delegate Echo? Is he connected still?
Yeah, maybe muted while we wait. So Elvis, I had some few contributions or questions I wanted to ask.
Maybe before you, will you mind if we hear from Ivor Dicta so that when we get in, we should just write on?
No, I don't mind, please, always.
Because he's so busy, he might die. They might call him for one intervention or another. So let's just have him while he's here.
Oh, thank you so much, guys. It was great to be here. I came in the middle of the presentation, but it was very nice to hear from somebody back home who's really working on a very important issue that's plaguing our people. You know, when I listen to this discussion, I have a lot of questions in my mind. And what worries me is that we seem to be dancing in a circle. By that, what I mean is we see cholera, we do something, then tomorrow we see cholera, we do something. Somebody had mentioned that we are just very reactive. The real question is, if we put all the data that we know about cholera in place, does anyone really believe that the things that we are doing today can prevent us from ever seeing another cholera breakout? To me, I look at this cholera as a marker of poverty. If people are poor, it is very difficult without a vaccine that's 100% effective to fight cholera, no matter what we do. I mean, if you look at the case of smallpox, how did we ever get to eradicate smallpox? If you don't have an effective vaccine, I don't see us really, because we can sit here today where we have to educate people to drink clean water. If the person doesn't have clean water, what does that information do to them? We have to tell people to have latrines. Even latrines are latrines, we make them. There is a big hole sitting right there. Flies get inside, pick the poop, bring it right to your food. How are you going to fight cholera? People go to the farms when they feel like they need to answer the call of nature in pooping. They go up the mountain in a thick bush, grass, and poop there. The rain falls, takes it to the stream, and you are downstream and you carry it and drink. How you? So this information, yeah, you're gonna get it by drinking dirty water. You're gonna get it if you don't have a toilet. Yeah, these are cosmetic solutions. To be candid, unless in a poor nation like ours, we have a vaccine, cholera is going to stay with us. And again, if somebody has any other method how you can fight this, if I cannot buy bottled water, should I die of thirst? If all I can afford is going to the stream in the villages, how am I going to fight cholera? So the delegate, I understand the delegate is here. And the good news is that there is some kind of a vaccine. I think our efforts, given that the other factors that propagate cholera are very difficult to modify, our real solution will be on how we effect massive immunization of these folks who live or wake up every morning asking themselves if they're going to have food. But we are here telling them you have to select the kind of food that you eat. Those solutions, in my mind, cannot work. Thank you.
Thank you, Dr. Dita Ivor. I know a lot of you do not introduce himself. Dr. Ivor is a mentor. He's an elder brother. He's an internist and a public health specialist, and also a gastroenterologist in the US who likes to actually give a lot back home. He's always advocating back home for us to have better healthcare, safety back home, and also during the COVID pandemic, he was very involved in advocating for us to get more information. And he has always been, even when I was in Cameroon, sacrificing his time to come and give back home. So he's always been that kind of person, and also a big supporter of all the physicians who migrated here, including me. We cannot forget it. So it's something I must tell them. So you're a true elder brother who wants everyone to succeed. So thank you very much. I'm sorry, Elvis, that I had to introduce Dr. Ivor, but what I wanted to say goes in the same line with what I'm contributing more to what Nicole is saying, because she's fighting a pandemic, but it involves a lot of other sectors. And as Dr. Dita said, cholera is a disease of the poor. If you go back to John Snow, back when the father of public health, you could see cholera eradicated a lot of people in Europe at the time. That was the disease that each time we have it, we didn't know exactly what was causing cholera. But we know that poverty is something that you cannot fight poverty just by using the Ministry of Health. You need to be able to take care of everything else. WHO did a meta-analysis back in 2020 to evaluate the things that have improved healthcare over the past 100 years for human survival. And hygiene and sanitation was number one, vaccination was number two. It shows you exactly the rest other things do not matter. Meaning if you put them in an analysis, all the cardiac caths we do, all the colonoscopies we do, I know we're all physicians thinking we're doing a lot. There was vaccine, there was hygiene and sanitation, and there was the discovery of antibiotics, which was clear out there, which made a difference in improving survival for humans from living above the age of 50 to going to the age of 80 years. That's really what made a difference. So I would go back to I'm trying to make it short. I'll give you an example where I grew up. Back home in Bamenda, I wanted to ask Dr. Nicole, which was my question, why are there no cases there? Do you think they are not reporting cases? Do you think that is because there is something different? Because where I grew up, in the center of Bamenda, there is no water. I grew up when there was water. So things are not even getting better. There is no water. We have not had water in the area where I grew up for the past 5 years. It's in the middle of the city of Bamenda. No drinking water for 5 years. We just recently put a borehole for the whole quarter, but that was a local initiative we did, but I could tell you they have no water there for more than 10 years, I can say so. But there is snake, it's now no longer snake calm water. So you see that this really has nothing to do with, there is calm water, but it doesn't flow. There are local initiatives that are not working. There is the Quen water. This is in somewhere around Foncha Street, Mile 3. You can see that this is a real problem back home. We need a lot of investment. We need a lot of things to go on. And if we cannot do that, which needs a lot of budget, then vaccine could be the way forward. But I just want to applaud Dr. Nicole for what they're doing and how they are trying to fight this little epidemics that we're having popping out everywhere in Cameroon and the strategies they're using. And please, I want to provide you with courage. It's going to be a difficult disease to eliminate in a setting where we're still fighting for the basics. So thank you very much.
Thank you, Chairman, for your comments and participation. I see that the regional delegate is around, and please, Dr. Echo Filbert, you have the floor. So you are muted. Please, can you unmute yourself? Thank you so much.
Thank you very much for inviting me on this platform. I want to greet everybody who is there. Unfortunately, I joined a little bit after the presentation, but I've gotten part of the discussions. I sincerely want to appreciate this forum, and I think the ideas that we get from each and everyone will help also us to move forward to try to ameliorate our strategies to fight not only this cholera, but also other epidemics. The outbreak of cholera in Cameroon and in the Southwest in particular is a call for concern. I want to say we know the causes of cholera. We know the problem of cholera. We know how to fight it. But again, as I heard all the speakers, it is a difficult situation. We are fighting, we are working now on emergency situation. We are working on immediate terms, on mid-terms, and on long terms. As all of us know, cholera is simple hygiene. Simple hygiene, which is a serious problem in our community. It seems as if we are teaching ourselves again how to do simple hygiene, hand washing, which is a major problem. When an epidemic starts, when COVID came, that was the same thing we were teaching. Today is cholera, same COVID has not gone. We are still teaching simple hygiene. It's very difficult for persons to appropriate the strategies and to move forward. I listened to the last speaker. It is very certain and clear. We can't eliminate cholera with the same situations. We can't. We will fight the epidemic. We will win the epidemic, but we can't eliminate cholera. I want to say most of the time, the cholera in the Southwest region usually starts from the maritime health districts. That is Bakassi, Ekondo, Titi, Mondimba, and Bonge. And we have noticed that most of these health districts are about 60 to 70% occupied by Nigerians. And most of them are very difficult to contain. We go there for even immunization. We had immunization campaigns. When we go there for immunizations, they go back to their country. And by the time we come back, they come back with cases of any epidemic that has to start from them and come to us. So it's a little bit difficult to handle from those areas. And it seems as if they usually settle only in semi-permanent structures. They go back and do more of permanent structures in their area, but when they come here, They do more of semi-permanent. And in these maritime areas, there is no way they can build toilets. They don't even think about toilets. They do everything by the shore side. And those are the problems we're having with them. However, even in mainland, we have problem of water, availability of water. Most of the catchment areas are usually contaminated. You have people who build their houses and open their tanks, open their septic tanks into streams where others are drinking on the other side. It's serious problem. And I heard somebody said, which is very clear, the Ministry of Public Health cannot do even 50% of all things that we have to do to fight cholera. We can manage 40, maybe 50, but I still think 50 is far-fetched. We have many stakeholders. Every person has to come on board. The council has to come on board. The Ministry of Education, all the educations have to come on board. The administrators have to come on board. The Ministry of Water has to come on board. As you see, from the perspective of the fight in the Southwest region, the coordinator of the response is the governor of the region. Why the governor? Because he is the only one who can bring on board all these stakeholders. I, as a delegate of the Ministry of Public Health, I cannot. I only have to work with partners like my partner, Dr. Nicole, and my other partner, UNICEF. Those are the persons who are helping us in all dimensions to fight this cholera. So it's something extremely difficult for us alone to do. Everybody has to come on board. With respect to, as I said, water is not something for today. I cannot assure you that it's something for today. It's really far-fetched. We need to do the simple things. We should not go and look for something that will not be feasible. What is feasible now is simple hygiene, is mass immunization, is try to treat. There are all ways of treating water. All of us have different sources of water. Let us treat them. If we cannot use the aqua taps that we are distributing free of charge regularly, they should do simple boiling. We don't advise them to do chlorine treatment at home, but they should do boiling. I think if we do these simple things, just these simple things, it will help us for the time being while waiting for the solution that for now is very, very, very infeasible. So let us do the simple ones first. That is the only way Cameroon, that we are now, can overcome this epidemic time and time again until the day that we have a solution. I heard somebody talk of why people build bars and so on without toilets, and the government tolerates. That is our government. In many aspects of life, our government is so tolerant. That's what they call administrative tolerance, but we tolerate to a fault. We believe that people are struggling to make ends meet, such that when they do simple businesses, even if they don't respect all the norms for those businesses, we tend to tolerate. Government tends to tolerate, thinking that we close them down. Maybe they will become armed robbers. Maybe they will be attacking us tomorrow. So we allow certain things of that sort to prosper. But again, everything advantage, and those are the disadvantages allowing this administrative tolerance of not just houses, toilets that people can easily use without, again, something before they can use. So as you see, it's a general something. As I heard one person, we are making a circle, turning at the same spot. But again, I simply think if we do the simple, the basic, treat your water before you drink, and mass immunization, I think that is the only way for now that we can overcome the problem. I'm open for remarks, for questions, and for ideas.
Merci beaucoup, merci infiniment pour votre participation, Dr. Eko. Merci beaucoup d'avoir pris un peu de votre temps pour nous joindre ce soir et pour nous donner votre avis sur la discussion en cours. Merci infiniment. Nous sommes honorés de vous avoir parmi nous et nous espérons vous avoir dans les prochaines éditions. Merci encore, merci infiniment.
Thank you very much.
Yeah. So Dr. Eko, we just want to thank you for your courage. Not every delegate wants to come over usually to the town hall, and you're invited here every time. We talk about health issues in Cameroon, and we try to talk about solutions, even ways to help back, get the diaspora to contribute back home. And so this is a good forum. If there's any topic you want us to address, just feel free. This is a forum where we have over 2,000 registered health workers, including physicians, nurses, scientists, epidemiologists, those who are working in the big pharma, those who are making changes, ordering drugs. So we're trying to bring all Cameroonians together, both English speaking and French speaking. And either language is really welcome here. So you are welcome, and thank you for coming and showing up. So in order to help Dr. Nicole put this into context, what they're doing in the WHO and you guys are actually implementing. And so it's wonderful having both of you.
Yeah, and Mona, what you said is true, because last time when the cholera was really at the peak, we had Larissa, the nurse practitioner in Maryland, who contacted me after the town hall and said, how can we help? And this question is very important. How can the diaspora help? How can somebody's little contribution make an impact? And I put her in touch with the nurses, the Cameroon Nurse Association, and she contacted them, and they did some donations, and they went from door to door and did some, some kind of distribution of resources and kits that help to improve sanitation. So there is just no action that will go without creating an impact. So the question is always, how can we help those of us in the diaspora? How can we help in terms of resources, in terms of our own knowledge and whatever we can contribute? And so we'll be reaching out to you with this, with answers to this question of how can those in the town hall who want to help to fight cholera, what kind of areas do you think we should think about in terms of our desire to contribute? So thank you, Delegate.
Yeah, thank you. I sincerely want to appreciate. I am very open. I think there is nobody who understands and knows everything. Being a coordinator of health in the region, I think having experts all over the world who can listen to us and chip in something, I think it will help us to go further. Our goal is to see that health in the region, not only in the region, but in the country, move to a different dimension. Helping, I think we are still lagging in many aspects. Our three main epicenters of this cholera is Limbe, is Tico, and is Boya. Those are three main epicenters. But Tico and Boya is completely different because we have clusters in the community. So we have quarters that are particularly touched in the community. So their strategies are a little bit different than in Limbe. In Limbe, it's practically the whole town. You have spotted cases everywhere. So the strategy that we used in Limbe before running short of financial resources was completely separating the treatment center that we created from the population. Build a wall between them and prohibiting the population from getting into the treatment center. In that course, we were providing them with food, morning, afternoon, evening. We had more than 230 patients. We had more than 90 staff inside that we mobilized, providing them with every treatment free of charge, and mobilized enough community health workers to do not just sensitization, but disinfections in the different communities in town. In that way, we drastically dropped down the cases of Limbe from the 230 to 0. When we ran short of resources, that is when we started having cases coming, and the treatment center was opened to the population. And of course, the trans-contamination between the treatment center and the population started all over, and we had to come back to about 100 and something cases in Limbe. But again, as I said, we're working closely and sincerely with huge support from WHO and UNICEF. They are our two major partners in all aspects of support, helping us with medications, helping us with PPEs, helping us with recruitment of community health workers, and even some health personnel in these treatment centers that can help us to manage and move forward. But again, partners are just there to support government. They can't replace government. That is where the trouble is. But coordination is coming from the governor, and we are trying to put hand on deck to see that all the other stakeholders come also on board, because it has been abandoned to the Minister of Public Health. I want to say clearly here, most of the other stakeholders have abandoned everything to public health, and public health cannot do. So we are trying to force locally and nationally to see that all the other stakeholders come on board, to see that we can confidently and effectively not just fight the epidemic that we are having. And I want to declare that this epidemic comes mostly during the transition between rainy and dry season. That's where we usually have this problem, lack of water. And when the rainy season just starts, people open their toilets into streams and everybody's contaminated. So I want to sincerely appreciate the forum. I think I'll be part of it regularly to listen to problems of not just our region, but of Cameroon, and to see how you people can help us, the coordinators of health, to do better things to improve the health situation of not just the region, but of the country. Thank you very much.
This is really heartwarming. Thank you, Delegate.
Indeed, Elvis, thank you. So maybe proceed with the hands that are on with questions. May I call on Brian Gonke Ajon to ask his question? First, please, can you present yourself? Tell us where you are joining from, and then ask your questions. Yeah, thank you.
Thank you very much. I'm Dr. Brian. I work in DRC with the UN Migration Agency. I'll be very succinct. I just have a few questions for Dr. Nicole, as well as contributions on the discussion topic on cholera. So my first question in Nicole, actually here in DRC is also endemic for cholera. And in the vaccination strategy for the expanded program for immunization here in DRC, they noticed that there has been an increase in vaccine hesitancy to cholera vaccines, including API vaccines, after the introduction of COVID-19 vaccines. So I would like to get Nicole's experience if during using vaccines as a strategy to combat cholera, if they have come across maybe more hesitancy than they had in the past due to the effect of introducing a new COVID vaccine into the population. My second contribution goes to cross-border collaboration. So I think it's critical that there should be some cross-border collaboration between Nigeria and Cameroon. And there are certain interventions that can be done. For example, I heard the delegate talking about people not getting vaccinated in Cameroon because when vaccination campaigns are organized, then they travel to Nigeria. I think one of the very interesting initiatives that was once set up in the East African region, when you had the Ebola outbreak that was declared a public health emergency of international concern, preparedness in neighboring countries ensured that Gavi provided vaccines that were used as a response mechanism in DRC, but as well, other countries vaccinated high-risk groups such as healthcare workers for preparedness. So in such a strategy, I think there is a need to push for cross-border collaboration with Nigeria, particularly on cholera, but as well other diseases. So ensuring that if there is a geographical strategy for vaccination, that we can push as well for maybe Nigeria to vaccinate at the same time. And then as well ensure that there is cross-border surveillance and information sharing between both countries. Now, my third intervention is with respect to cholera anticipatory action. So currently, UN OCHA, the UN Office for Coordination of Humanitarian Affairs, have what they call cholera anticipatory action, where they put aside funds for country. So they allocate funds for country, and then they set up indicators, which if they are reached, then such resources can now automatically be disbursed to be used for a response. And this is currently being piloted in DRC and I think Syria. And the whole idea is we don't want to have an outbreak, and then that's when we are requesting for organizations to write concept notes to try to mobilize funding, which can take so many months and would let the outbreak spread before we can contain it. So I would like to ask Nicole, when it comes to resource mobilization, are these things that they are looking at to ensure that they can reduce the time lag between when an emergency is triggered and the mobilization of resources and the response? Now, one other contribution I'd like to make, normally the literature says the Vibrio cholerae bacteria can stay in brackish water for around 3 years. So I think we already have to put in our mind that it's going to be for a long haul, that even if we have 0 cases now, the likelihood that you could still have the bacteria in the environment that could cause other outbreaks afterwards is still there. And what we've seen here in DRC is similar to what is happening in Cameroon. For example, in Nicole's presentation, she talked about 3 years when there were very few cases. And what we've noticed as well here is due to vaccinations, people have immunity for 3 to 5 years, which wanes in 3 to 5 years. So there could be a tendency to have a cyclical pattern after 3 to 5 years when the immunity from vaccinated populations wanes down. So I think those are my contributions for now. And the last thing on the CATI approach, the CATI approach is really best when at the beginning of the outbreak or towards the end. And I'd like to ask Nicole's opinion as well. Just when districts are recording their first cases, how quick is the response, and how quick is it to put a strategy like CATI when at that point in time there would be a very few number of cases when CATI, the evidence on CATI's on the CATI intervention effectiveness has really been demonstrated at the beginning of the outbreak? Thank you very much.
So is Dr. Christelle there? Maybe she may have been locked out because her lights went out. So I just want to thank, it's been a wonderful session. And Dr. Nicole, do you have any contributions to? Excellent question.
So, Mona, before Nicole comes in.
If Nicole is not there, I want to respond to the last speaker.
Okay. Go ahead.
Yes, I just want to say I've listened to him. He's just said very interesting things. I want to make certain things clear here. I just said we had 3 epicenters, Limbe, Tsiko, and Boya. It's not that cholera did not spread to other places, but the response that we implemented in these other places, that's the CATI strategy, helped us a lot. In Kumba, in Moyoka, in Mamfi, we responded so promptly and using the CATI strategy. That's how we succeeded. Unfortunately, in Limbe and Boya, let's say so, we didn't respond that fast. Why didn't we respond that fast? We, in the maritime areas, is MSF that was at the forefront. The Ministry of Public Health, Delegation of Public Health, was just a supervisory body. And when the cases crossed to Limbe, that is when MSF started having some administrative problems with the government. And their response was not as adequate as they have been doing or they had done in the maritime health districts. That is why the response was a little bit slow and not adapted properly. And that is why we had what we had in Limbe and in Buea, and of course in Tico. So we could not implement the CATI strategy in these areas because we were already late. Unfortunately, we are where we are. But I think what he said is very interesting. If our response is very prompt in
Hi, thanks so much for, I'm sure we lost you, or if you finished what you were saying. Dr. Eko, are you still with us? Brian, is he still with us?
I think yeah, the delegate is still with us, but I think he's we might not be hearing getting what he's saying if he's talking, because he's maybe we have connection problems.
Oh yeah.
But I think those were very great. First, those were very great questions from Dr. Brian Ngonge. I think it's a really very insightful comments you made, and I also think the delegate for his response as well to each of those comments that were raised. I think we may have lost Christelle as well, but I think she might be joining us right back. And yeah, thanks. I don't know, I see Nicole's hand is up. Did you want to comment to some of these before we move on?
I think they have hands that were up long ago.
Yeah, yeah, at least Nicole, she has to respond. So
yes, Brian, thank you very much. I just wanted to react to Brian's comments. He made a comment about vaccine hesitancy. Yes, Cameroon implemented a mass vaccination in response to the cholera outbreak in 2020 in Kribi district, Littoral as well, and Southwest, but just the Mabeta health area in Limbe district. Limbe and Tico as well, I think, yeah. So vaccine hesitancy was still quite much in that time because the vaccination coverage it didn't exceed 60% when compared to now, when the country has reached about 89% during the last campaign. So the impact of the COVID-19 was really felt on the mass vaccination campaign. But now the country has also emphasized communication on a cholera vaccine because people didn't know there is a cholera vaccine and what immunity confers and why do we have to vaccinate, because people were like, we don't have water and you come with your vaccines, why? So now people are starting to understand that immunization can help us buy time, because we know that people wouldn't build toilets and improve water sources just in a month or in a year. So immunization is one way to buy time while putting the fire off. So that was the response to vaccine hesitancy. Regarding cross-border movement, it's still really, really challenging. At the beginning of the outbreak, we were planning to support the country to organize cross-border meetings, but up till now, it's not really the kind of meetings we should have, it requires really high level advocacy as well. But with Chad, it has been a success, but it was really a local cross-border meeting. So the collaboration between the countries is still insufficient. When West Africa had the massive outbreak with Nigeria, Togo, Niger, and so on, they invited Cameroon to participate in their meetings, their cross-border meetings. But then the outbreak stopped there and the meeting stopped. Now Cameroon has an outbreak, Nigeria too somehow, but we no longer see the meetings. We've been asking for the meetings, and it seems to me that sometimes Central Africa is also left behind, because West Africa, when there's something, you see the mobilization, and it's not the same when it's Central Africa. I'm really sorry to say that. So we still have a lot to do when talking about cross-border movement. And yes, for Kati is really great at the beginning or at the end of an outbreak. But when the outbreak is already that extensive, it's really, really hard to do Kati, but unless you couple it with other strategies like mass vaccination in some districts and Kati in districts that don't have a very high incidence of cholera. Like in the West region, if we do Kati now, we are going to stop the outbreak there. But doing Kati now in Littoral, for instance, is complex because you have more than 7 health districts in outbreak, and it can be very demanding in terms of resource, finances, materials, and so on. So yeah, thank you very much for giving me the floor.
Thank you so much, Nicole, for really clarifying these issues and really painting a true picture of what is happening on the ground and some of the challenges. And it's really it's something that requires this kind of mastery of the situation to be able to advise, because there's no copy and paste in these issues. Interventions have to be really, really situation and context based. And so I'm happy you're giving us this, painting this picture. I don't know if Dr. Echo is still here. I wanted to I'll just ask him one question while I think we have Mokong, his hand is up, and Keka Frederick. Any of you who has a question or the hands were up long ago, just let me know.
Yeah, sure. I just had a really quick question to ask. I think the importance, I think we've come to recognize how important just field epidemiologists are, and just applied epidemiologists that can be quickly deployed when there is an outbreak. Similar to what we have with firefighters, when you have a house that is burning and you can call firefighters, they intervene almost immediately, and they respond, and they are able to circumscribe the emergency. I think in the similar fashion, having a set of fighters in public health, similar to that, to firefighters, that can be immediately recruited and can be expected to really respond in real time whenever there is such an outbreak. And I think the usefulness of the importance of these kinds of epidemiologists or outbreak investigation people can really help to greatly, who are trained and have the ability to, case finding and case identification, case ascertainment, and really build that really solid database. The more data you can collect, it really helps you to build a hypothesis of what might be happening, and you can definitely from those preliminary data draw some interventions that could really help to interrupt the chains of transmission. So I think I know Cameroon has the CAFE-TP program, but I don't know how much of those alumni are being redeployed in the field to respond to these kinds of emergencies. So do you know, Nicole, the CAFE-TP program, or just in general, how field epidemiologists are being used in these kinds of public health response?
Yes, Brian, I think the CAFE-TP, they do help a lot. like I was saying, the health professionals are really at the forefront of many health emergency, and the Café TP come to support the response. Even though they are interns, they are at the forefront of investigations and even rapid response teams. I don't know how good it is in all the regions, but we see that in most of the regions they intervene, but of course it's not still enough because the demand is higher. The outbreak is really complex now, and we need more resources. So I would say yes, they intervene, but a lot more still has to be done. Thank you very much.
Great. And Gael, you still have a question?
Okay, thank you. Good evening, everyone. I'm Dr. Kwame Gael. I'm in the West region of Cameroon, and I'm a field epidemiologist and Café TP alumni. So I would just like to contribute as concerns Nicole's answer. And concerning the work of Café TP alumni, concerning the response in the West region, since the first case, the regional incident management system was activated, and basically the people who are responding are Café TP frontline alumni. Yeah, there are frontline alumni who were trained in the 3-month course, and they really help a big deal. During the COVID-19 pandemic, they were really of great importance, and now they are doing a great job. And as Nicole said, there are always, there is still need for more and constant support. That's what I can say. Thank you.
Thank you so much, Gael, for that timely intervention just to collaborate with what we were told about Café TP program. Thank you so much, and we pray that this program continues. Keka Frederick. Frederick. Maybe you have a problem with sound. I think I saw you on mute. Frederick, are you still with us? Okay, we lost Frederick. What about Mukong? Do we still have Mukong?
Yeah.
Okay. If we don't have Mukong, I wanted to bring back Dr. Echo if possible. Dr. Echo, are you still with us?
Yes, I'm still with you people.
Okay, just one question, if you can help me with this. You said something that was really heartwarming. You, the treatment center was isolated, and there was a real wall barrier to prevent transmission from the, cross transmission from the treatment area with the population. This was, we had patients here and nurses and doctors all in one place, and you were feeding them morning till evening, preventing them from even going home. Do you have the number in terms of figures, how many healthcare workers were in this center working at that time in Limbe specifically? Just a rough number, the number of healthcare workers.
At that time, we had about 80 staff.
80?
Yes, in the treatment center, yeah.
Was there any special motivation or incentive to this staff?
I will love your question. The incentive was their feeding, sincerely. The minister promised when he came, he promised motivation, financial motivation, and asked me to forward the names to him, which I did 2 months ago. And sincerely, unfortunately,
It has
As of
Michael.
now, it has not been materialized, even though of recent, the Director of Human Resource called me that they are still working on it.
Okay. If you take, it's really heartwarming because I know what medical doctors and nurses went through here during the pandemic. There were all kinds of incentives to keep them really motivated in doing this work. At the level of the town hall, I just want to make a promise. In the next 2 weeks, the chair is going to make some effort together with the moderators. We are going to mobilize £1 million and send to you to give to those 80 staff. Even if it ends up just being 10,000, we just want to tell them that they did a great job. So expect £1 million from the town hall in 2 weeks' time maximum. This is just a way to say something has to be done to this kind of people. They are special people. They took the risk. They stood at the forefront. They risked their lives. So we just want to say that that's what we're going to do. And the chair has endorsed this, and we are going to do that. And many more people will. If people think about ways you can help, sometimes it's not just about donating PPEs. Sometimes it's not just about buying cholera medications. Sometimes it's just about thinking about those healthcare workers that are at the forefront and how we can motivate them to continue to do this kind of work. So thank you, Dr. Eko, and we're going to the chair is going to get in touch with you on this.
Yeah, Elvis, it's really heartwarming to see that people do sacrifice like that. And I can tell you in the peak of the pandemic, we felt loved in New York. Yeah, we did feel loved, and that's why no matter what happens, we cannot forget it. We felt the population loved us. We felt every single restaurant or every single Amazon and the others, they all supported healthcare workers one way or the other.
Yeah.
Meaning you really felt that there was love coming in. And though the US setting is more of a private setting most of the time, but you could feel support coming in from the community, and you could feel you're not standing alone. When we had the surge in New York, where we had thousands of people die a day, but you went to work at some days just because you felt every single person in the community really knows what you guys were going through, or thought about they knew what you guys were going through. So always going to be important to support our healthcare workers, including the cleaners, the nurses, everyone who is there trying to take care of everything that is happening. You can imagine the number of people having watery stools and all those areas and how to take care. And those number of healthcare workers who got sick, that would have been my next question. How many healthcare workers actually had cholera as a result of working there? So it's heartwarming.
So I see Frederick is back and Mokom is back. If we get these two last questions, then we can end the session and stay at the parking lot. So Mokom?
Thank you very much, sir. Can you hear me?
Oh, it's Frederick now speaking, correct?
Yeah, this is Frederick. Oh, sorry,
yeah.
I had problems with the computer, so I struggled to switch over to the mobile phone.
Okay, go ahead.
Thanks for bringing me on to this wonderful platform. I really much appreciate my boss, the regional delegate for the Southwest, has said quite much. So there are a lot of things I won't go to that he's touched already. But just to note a few things, that if it's true, we are into this challenge, but if we've been able to make some gains, I think the CAFETP program has greatly helped this region since the beginning of the COVID-19, and then responding to other epidemics. A lot of the people who have been responding have benefited from that program, and it's greatly improved the style of intervention. And of course, we've seen the results in different areas. Myself, I'm a frontliner in that program, and it's greatly shaped my way of intervention. We do pray and hope that it continues. Much appreciation for the mobilization that you've done and you've promised to the healthcare workers, the foot soldiers who have been taking all the risk, working at all hours to save mankind. We thank you very much for that gesture. It will go a long way. Our borders, you know, we have a very porous border, which is quite difficult to monitor, particularly again, considering the context, particular context in which we carrying out our interventions, in that of insecurity. You know, at times some of these interventions are not quite easy in some areas. You have a lot of people transiting through paths that cannot be monitored. Of course, at times with a lot of risk of moving infections from one place to another. So it's quite challenging. And like the delegate already mentioned, due to some administrative challenges with one of our key partners who's been helping us a lot, that's the MSF, who at this time have shut down operations in the region. It's quite difficult. I remember very well when we were able to quench down the cholera epidemic around Kondo Titin Bamuso. They were very, very much active on the ground. They were present on the ground. In fact, the case management team that was there, the structure, the material, that those who set it up and were just there to follow up and see that things were done correctly. So with the withdrawal of their interventions, it brings upon us a little bit more pressure. That's why at this point in time, we trying to engage more and more with the community leaders and community health workers to really see that we can reorientate and change their mentality so that they appropriate the messages that we come with, the appropriate strategies that we come with in order to curb the spread of this epidemic at the level of the community. Like somebody said it, long-term measures, very good, but looking at some of the, in fact, if we take the coastal part, is quite difficult. Everywhere you will not even find, you'll not find potable water. We've attempted water trucking. We've attempted moving water, transporting water from Boya at times to as far as Bakassi, which goes, of course, with huge financial demands. That can only go on for a short while. But if we really succeed more and more in terms of sensitization, educate these communities to really engage and appropriate these basic things that would help us prevent the spread of this epidemic, is what can really help us at the level of the communities. For now, like the delegate noted it, the health actors, they are like the sapeur-pompier. Everything has been abandoned to them. It's like it's their problem. There are things we have identified in all these places. Most often you see the risk factors are almost the same, but most of these problems to be addressed is beyond the scope of the health team. So all the other sectors, they have their role to play, and if they do not do it, then I'm afraid we'll just keep going around this cycle from time to time. We have quite enormous challenges at this time.
Frederick, you might want to wrap up.
Challenges ranging from human to material and, of course, financial resources at this time. These community workers we're talking about, for them to go out and do work, you need to provide them at least some transport, some token for feeding and stuff. You need to provide material that they need for work. They need boots at times, might need raincoats, might need megaphones and stuff like that. So all of this gets into this package. At times you need to go a mile to hire some extra hands. Like we used a lot of volunteers to beef up the inadequate human resources that we have. And of course, without any form of motivation, some of these volunteers are not quite, they add morale. They've lost the morale to again come on board to assist at this time. So in this light, I just want to once again appreciate you for this wonderful platform and the support that you people are trying to mobilize to get us moving on. Thank you very much, sir.
Thank you so much, Frederick, and really thank you for trying to even just paint a picture of some of the things that are helpful and useful, like just having those booths and those megaphones for community healthcare workers. It just completely continues to enlighten us on some of the ways in which we can be of help. Thank you for your elaborate explanation. And Daniel Mabongo, I see your hand up.
Yeah, good evening. I'm sorry I took the meeting a bit late. It's just a few contribution.
Yeah, just tell us about you yourself and where you're dialing in from.
Yeah, I'm Daniel Mabongo. I'm medical doctor, senior field epidemiologist. I'm working in the Southwest region. I'm the RTG for HIV for the region. So it's just in another aspect. I don't know if you talk about this aspect before me. It's when you are looking the epic curve of this outbreak, especially in Limbetico. It's looking like sometimes you have the impression that you have the control, and then suddenly we have the increase of number of cases and all the things are going around. So the question is now how concerning the risk factor. It's true that, okay, we just have hypotheses, but in this kind of situation, one important aspect, according to me, is research, operational research, because now we don't have the clear overview of the real risk factor concerning this outbreak. We have hypotheses. All those we have is our hypothesis, no proof, scientific proof. And the second thing is that we implement and we carry out a lot of sensitization in community, a lot of wash sensitization in community. And the question is, if now we have a resurgence of cases of cholera, what is the level of adherence to the sensitization measures by the population? We can have this information, we can have hypotheses and say that, okay, no, there's not a good adherence, but I'm not sure that it can be a difference between the different area. So I think that one of the important aspects on this kind of outbreak or on this level of outbreak is research, to look a way to finance is not a big research, even a simple case control study, just to look exactly what is happening, what are the real risk factor, what are the score of adherence, and then it can be very helpful to address this strategy. Because when you are working with hypotheses, your hypothesis can be true or false. So operational research can be very helpful in this kind of situation. Thank you.
Yeah, thank you very much, Daniel. You're very correct. Operational research is very important, and as well as making sure we have more data scientists who are interested in health data, so we can be able to collect and use our own data to answer questions that are important to us. And when we have data, we can actually play around with this data to actually really know what is happening and really, make informed decision based on analysis on this data. So you're very correct. We really need to conduct some research and not just base our decisions on on assumptions or hypotheses. Though some of those hypotheses can really seem real to us and true, but science is about facts and data, so we need it. So the last person we have on the hand up now is Mokong. I don't know if you're ready now with your question.
Yes, good evening, sir.
Hi, nice to see you again.
Yeah, thank you very much. Actually, I had some network interruptions, but I'm back. Okay, I actually appreciate the forum. I'm Doris Fru. I'm a nurse by profession. I live in Bamenda, the former interim assistant general supervision of regional hospital Bamenda for the past 5 years. So I am here to appreciate the team, and I'm very grateful to be part of this grandiose forum. Actually, I actually look at the cholera outbreak in different folds, because looking at cholera outbreak, we should also try to identify the reasons. And when I look at Bamenda, Bamenda is a potential reason for cholera outbreak. Why do I say so? When you look at Bamenda, is the closest neighbor to the Western region, the next neighbor to the Southwest region. And we, even at the heart of the town, this moment, it is very, very strategic due to security threats. Dust, dirt, waste, everything is dumped haphazardly. Even at the food market, you can go there, you see how they sell food on top of refuge. Our company that used to clean cannot clean any longer. So apart from the water shortage, we should know that Bamenda is the next zone if we cannot do something. And I was about to ask Dr. Nicole, what are the strategic plans to put in place to identify reasons, and what are the way forward? Thank you very much.
Thank you so much for that question. We've been seeing images of stockpiles of refuge along the streets of Bamenda recently due to the non-performance of the refuge disposal company and related to all the risks concerned. We really appreciate the fact that you can see this and you can think about this. And I think Nicole is ready to give an answer.
Okay, thank you.
Hi, Nicole.
Yes, thank you very much for giving me the floor. I would just like to say that the country just achieved a major step in identifying the cholera hotspots. Hotspots are like geographical areas identified as being prone or vulnerable to like we're talking about cholera, so to cholera outbreaks. And the country has mapped out all the hotspots, and we have also prioritized the hotspots so that interventions can start in the district that are priorities, and all the regions have done it. It's going to be published soon. And it's the first step towards elimination of cholera, identifying where it occurs, where it's a priority to intervene. Where do we start? Because if we have to eliminate cholera by 2030, we cannot build toilets everywhere at the same time, or we cannot put water sources in all corners at the same time. So we have to prioritize the interventions we are going to put in place. And so the country has done that, and it was done in March. And that is what will serve as the advocacy to the Prime Minister and the Presidency. Actually, the elimination plan will be led by the Prime Ministers. Things are being put in place so that it happens next month. And it's really going to be a very high-level advocacy meeting, because the country needs people, great funders, because it's a whole development project. And I want to reassure the previous speaker that the Northwest was identified as high priority, but you know, you cannot prioritize all the districts, all the health districts in the Northwest, because the country is big. So in the Northwest, there are some health districts that were identified as very high priority because of the humanitarian situation ongoing there. And so all regions right now know their hotspots, and we know where we have to start, where we have to focus the intervention so the country achieves elimination. And the country is going to set up a plan to intervene year by year. And like I was saying, not everywhere at the same time, because it's not possible. It required funding and technical support and whatsoever. So just so you know, the methodology used is one recommended by the Global Task Force for Cholera Control for identification of hotspots. You can check it online. I'm just going to put the link so that you see what was done. And I think the country is preparing to publish it. Thank you.
Oh, thank you so much, Nicole. And very always excited to know that there is something being done. And before we wrap up, something came to my mind, and I think Kenji is here. Well, let's talk about diagnosis. Is it just eminent that someone with running watery stool should just be presumed as, having cholera, or are there ways in which you can suggest that before the first case is being diagnosed, maybe there are already 50 cases in the community that were missed or that the diagnoses were missed? How can we optimize diagnosis to ensure that there is early detection so we can ensure that this is controlled within a very short space of time without letting the window out for a widespread? Kenji, is there any thoughts about how we can improve or how diagnosis can be improved? What is being done in the field of diagnosis and how can that be improved?
Yeah, thank you so much, Aris. This is a very important topic. I was a little bit worried, when I heard that it took some time to confirm the first case. I think the gold standard for cholera diagnosis still remains culture. But as you imagine, setting up culture is usually expensive as well. Not all labs are able to perform that. But I think that we've learned our lesson so much that my expectations will be that probably at least in all 10 regions, we should have focal points where we can do culture. The good thing is that there are rapid diagnostic test kits that are available for cholera. Sensitivity could still be an issue, but some of them are very specific. And I know there's one that is endorsed by WHO, and that's usually the first line, right? In the absence of culture, you could always use those rapid diagnostic test kits as your first line of testing, to be able to just screen people in the field. Of course, anybody presenting with watery stool, you can't just assume that it's cholera. Cholera 101, we always say rice water stool. That could always give you, some kind of suspicion. But of course, it cannot only end there. You must be able to, identify the pathogen to actually say that it's cholera. And as you know, there are several things that you have to do, serotyping to be able to know, which serotype is circulating and all those things. Yeah, so in terms of diagnosis, much has been done. At least now there are rapid diagnostic test kits that can be used. The same strategy as COVID, right? Which I always say, go first with your RDTs on the field. Those that are positive, you can start treating them. Those that are negative, you cannot proceed, to do your PCR and all the like. So same to with cholera, right? You can always go your rapid diagnostic test kit, then you use your culture to confirm. You must always confirm with culture before you can actually declare this an outbreak.
Oh.
Thank you.
Well, thank you so much, Kenji. And are there rapid diagnostic test kits for cholera in Cameroon, Dr. Eko? Or maybe if Nicole can answer.
Yes, I just wanted to say that the WHO makes provision for laboratory kits in the country. We usually pre-position rapid diagnostic tests and also kits for culture in laboratories that are identified for cholera confirmation. I think there are 5 main laboratories, and for the rapid diagnostic tests, we position them at the level of the regions, and the regions are expected to pre-position at the district level, so that when there is a case, the first thing can be doing a rapid diagnostic test and using carry bless to take the sample to the next laboratory for confirmation. And I would also like to add that the Southwest now can confirm cholera cases because there's one laboratory at the University of Boya. I think the Laboratory of Emerging Infectious Diseases, which really works greatly. And I'm saying that also because we have a lot of researchers here and funding opportunities, and we hope that people can also support the region more. Thank you.
Oh, thank you very much for that. Now, I would like to call on Dr. Faikal to ask his question. I see his hand is up. We remember he was our speaker last week, and we had a very interesting conversation with Carl and Brian last week. So Carl, please, the floor is yours.
Thank you, Doctor. So my question just was same question like yours on diagnostics, and I wanted to take this opportunity with having Dr. Kenji on same platform, and maybe later on I will maybe send him an inbox. My main problem was at Epicenter in Cameroon, we evaluated rapid diagnostic test kits, 3 types. That's Cholkit, Crystal, and SD Bioline, used by nurses and laboratory technicians from 2020 outbreak, from 2019 to 2020 outbreak. And I'm currently analyzing the data from these. So, but what I'm saying is we also did enrichment with alkaline peptone water, APW. So my question to Dr. Kenji is, normally we expect to see like an improvement in the sensitivity after using the alkaline peptone water. Yes, these 3 test kits, the RDTs, they had quite nice performances, quite nice sensitivities and specificities, and we are planning to recommend this to the Ministry of Health. But we had this difficulty with APW in the sense that it did not actually improve the performance of this rapid diagnostic test, and we were looking for possible explanations to this. Could you have some insights on this kind of difficulty?
Alkaline, thanks for that question. Enrichment mostly helps for culture, because for culture, you want to keep the organism alive, right? Because it's a fastidious organism. It may not really change much in terms of rapid diagnostic test kits, because I always remind people, rapid diagnostic test kit is not like PCR, where the pathogen that you have is going to to multiply, right? You are enriching. Enrichment is not as if you are incubating it, for the bacteria to continue to grow and all those things. So that's why you may not see an effect, when you enrich in terms of rapid diagnostic test kits, because you are not amplifying the bacteria. The bacterial load will probably be the same. Now, but in terms of culture, it's going to help, because for culture, you want that bacteria to be alive. For RDT, whether the bacteria is alive or dead, it doesn't really matter. It's still going to pick it up, right? Because you have the antibody that you have produced against this particular antigen that should be able to pick it up. So that would be my response to that.
Wow.
Okay, thank you.
Thank you very much for that response, Dr. Kenji. It's always a pleasure to have you. Ladies and gentlemen, it's been a very wonderful session today at the Cameroon Town Hall for Healthcare Professionals. I'll just take a round with the moderators who are on set to get their last comments and words before we wrap up. And Christelle, tu as beaucoup parlé aujourd'hui en français, en anglais. Maintenant, je vous demande de parler en français.
Merci Elvis, merci beaucoup. Merci infiniment à Dr. Fouda, merci grandement pour son temps malgré la connexion qui est un peu perturbée, mais merci infiniment pour prendre de son temps pour préparer cette édition. Merci beaucoup. Je voudrais dire aussi un grand merci au Dr. Rico Filbert, le délégué régional pour la santé publique du Sud-Ouest, pour sa participation à cette édition. Un merci spécial à tous les participants, à tous ceux qui ont contribué, tous ceux qui ont participé. Merci infiniment de vous avoir connecté à cette nouvelle édition de Cameroon Town Hall. Au plaisir de vous revoir dans 2 semaines pour une nouvelle édition. Merci à toi, Elvis, d'avoir pris le relais quand ma connexion s'est arrêtée. Merci à tout le monde et au chairman. Bon week-end à chacun. Merci.
Bon week-end, Christelle. Bon week-end. Merci beaucoup pour votre participation aussi. Brian?
Yeah, thanks. I just on the same light, I just wanted to really express deep gratitude to Dr. Fouda, Nicole, for accepting to talk today on the cholera epidemic in Cameroon. And I also want to really thank the regional delegate for the Southwest region as well for his presence and his engagement and his participation during this session. I just want to let you know that we are available to help. We are available in different content areas that you might need any form of assistance with. We are available to provide our expertise in different areas. And I really want to thank you very much for joining us today. Thank you so much. We are very grateful. I also want to end by saying thank you to all the town hall participants, those that joined us today for this discussion. I think it was a very enriching session to talk about. And thanks also to all the other co-moderators with us today. Thank you very much. Over to you, Ellis.
Yeah, thanks, Brian. It's always a pleasure to get you. Our chair, I hand you the floor to say the last words to our participants before we close up.
Yeah, Elvis, I'm always baffled by the number of people we get here. Each session, we were up to almost 50 people always participating, people coming in. I would like to say a special thank you to the moderators. I always say that you guys are real heroes, sacrificing your time despite everything that is going on with your families, with your jobs, and being here every 14 days and trying to coordinate this and trying to get presenters for the town hall. And a big thank you to Dr. Nicole for really accepting to share with us. I've learned a lot, really. They say you can't stop learning. I've learned a lot about what was done. I left Cameroon already almost, I think 10 years ago, getting to that amount of time. And a lot have changed. I worked at the district level. I worked at the central level at a certain stage, but I have learned a lot. And the good thing about it is that we keep trying to improve things. And we have a lot of partners, and we can keep learning and trying to stop pandemics and trying to stop epidemics from happening. And the delegate, I know exactly what it takes. I have been around several delegates. I've never been one by myself. I have friends who are delegates. Dr. Eko, I want to thank you for coming to the town hall, for being willing to participate and answer questions. Not all delegates are like you. If we have delegates like you, Cameroon is going to change. Healthcare is going to move forward, and that's the truth about it. Because just putting yourself out there and be willing to address these problems and talk about them frankly and invite us, your region, it's wonderful. So you have invited us and we are going to come and provide, not come to provide help and to learn from you also, because I always say it's two ways. I did a lot of time in Cameroon and I know exactly what I can learn from my colleagues back home. And I think they may be able to learn some little things from us, but we can learn from each other. And we're here to make sure that our goal is to help our fathers, our brothers, our mothers, and our sisters back home to have the best of healthcare, and to support you guys. For having left the country and being in the diaspora does not mean we cannot participate. So thank you very much. And I hope all other delegates and everyone who is involved in healthcare sees it like you. So thank you very much. And I want to say a big thank you.
Yeah, thank you so much, our chair, Mono, for always looking for this as experts. Your leadership for the town hall for this past 2 years has been amazing. I think if they were to give any award to anyone for this past 2 years, I think you will be the one in terms of healthcare and whatever impact this has on our healthcare back home. Every day we come here is an opportunity to learn. If I never attended this session and I hear about Kati in cholera intervention, I'll think of a certain lady in Balinyonga who is called Kati. But today, at least I know it means case area targeted intervention. And so much of that we have learned today. Thank you so much, Dr. Nicole Fouda, for enlightening us and for giving us all the information about cholera. Your effort, not just in Cameroon, but in Africa is huge. We've known that for us to achieve eradication, it requires interministerial, intersectoral collaboration. We must put our heads together to do the basics that needs us to actually know the root cause of cholera and start solving this problem from the root cause. Of course, let's not ignore also the importance of immunization, which has proven to be one of the ways in which we can actually fight things that we cannot actually achieve through basic interventions on educations and on hygiene and sanitation. So I want to thank you for the time you took to really do this presentation, and thank you to all our participants. A special thanks to the delegate. You've said it all. He is one of its kind, of a kind, who has taken time on his weekend to attend this session and to speak on these very difficult issues, which sometimes people think that speaking about it is about being against the system or for the system. Science does not lie. Science is science. The facts are there. Whether you are pro-system or you are against the system or you are for the system, science remains science. And our effort on this platform is to make things better for our country. We don't take sides. We are apolitical. We have no alienation to any politics. Here we talk science, and our effort here is to make sure that things get better as far as the healthcare sector is concerned for our country. Thank you very much, our delegate, Dr. Echo, for being on this platform today. And we hope you encourage your colleagues from other regions to do the same. Thank you once again, ladies and gentlemen, for being part of this session. We do hope that you are going to tune in for another session in a fortnight where we shall be here talking of another very important health issue. So I wish you a very pleasant weekend. And